So let me now introduce you to our guest presenters. Julie Johnson is a professor in the Department of Surgery and the Center for Healthcare Studies at Northwestern University. Dr. Johnson has an MPH from the University of North Carolina and a PhD in evaluative clinical sciences from Dartmouth. She has extensive experience conducting qualitative research as part of implementation research studies, and she has used qualitative evaluation methods to study errors in ambulatory pediatric settings, to conduct observations in pediatric cardiac surgery, to observe how clinical teams function on inpatient medicine rounds, and to improve handovers or patient care. She has published over 81 peer-reviewed articles, 46 book chapters, and 5 books, all related to quality improvement, patient safety, and clinical microsystems. Dr. Johnson serves as an associate editor of BMJ Quality and Safety. And as a teacher, Dr. Johnson has a special interest in developing and using serious games as a way to engage learners around important concepts related to understanding and improving the quality and safety of healthcare. Dr. Paul Barach is double board certified in anesthesiology and critical care from the Massachusetts General Hospital, affiliated with Harvard Medical School, and he is a trained health services researcher with advanced postgraduate training in quality improvement and medical education. Dr. Barach has extensive experience in working with clinicians and managing large healthcare and broader public sector engagements as a hospital executive, and advising and consulting to academic medical centers and hospitals, government, and industry on healthcare delivery, quality improvement, medical education, and patient safety. He holds academic positions as guest professor at universities of Oslo and Stavanger in Norway, and he works with the National Board of Medical Examiners and is president of Barach Innovation. He's published more than 400 publications, 3 books, and has presented at international and national conferences on more than 500 occasions, including over 60 keynote addresses. Helen Haskell is the founder of the nonprofit patient organization Mothers Against Medical Error, and she is president of Consumers Advancing Patient Safety. Since the medical error death of her young son Lewis in 2000, Helen has devoted herself to patient safety advocacy in a variety of fields, including diagnostic error reduction, rapid response, infection prevention, and patient engagement, among others. She serves on boards and committees for a number of national and international organizations working on patient safety, healthcare quality, and patient engagement, and she is author and co-author of numerous articles and patient educational materials on patient safety and quality. Her son's story has been featured in several educational videos, including the Lewis Blackman story from Transparent Health, which is shown in hospitals and medical and nursing schools across the country. So with that, I will now turn things over to our first presenter, Julie Johnson.
Thank you, Sophie, and welcome everyone. Thanks for joining us today. We've planned an exciting session to tell you about this book that we've published and how we think we can use patient stories to improve our teaching and ultimately to improve patient care. So we want to start by talking about the magnitude of preventable harm and the challenges that we face in making healthcare safe for all patients. And my co-editor, Paul Barach, will handle that part of the presentation. And then we'll turn to Helen Haskell so she can tell us about her experience and specifically around the death of her son, Lewis. And from there, we're going to talk about what we actually did to create this book of stories and how we think we can use these to really create a powerful patient safety and quality curriculum. So I hope you've had a chance to request a copy of the book to think about how you might use that in your teaching, and I'm sure that Jones Bartlett will be following up with you about how you can secure your own copy. It's 24 case studies, and these are based on real events, and what we wanted to do with this book is have the patients or the family members in a lot of the cases have the opportunity to tell the story from their perspective. And this is quite challenging, as you can imagine. And Helen, in her work as a patient advocate, has connections to many of these people and their stories and their families. So we have this opportunity to choose just a few stories. Unfortunately, there's so many, so we only have just a very small slice of all the events that have happened, but a few of the stories that we thought were compelling that we could actually then design a case study that we could use in the classroom setting. So in each case, we chose a standard format. So we start with an introduction, a small background about the event and about the case, sometimes about the condition that brought the patient into the hospital, and then the case told from the patient perspective. A case discussion that was co-written by the editors, and then a series of questions that you can use in a classroom setting. And we also had the opportunity to really make this an international teaching tool. So we have cases from several different countries. So it's not just a U.S. perspective. It's including other countries as well. So I'm going to hand this over to my colleague Paul Barach now, who's going to really set the stage for quality and safety, and before we move on to Helen talking about her son's experience.
Julie, thank you. As you all know, safety and quality challenges are not new, but the evidence continues to grow around the world about a large amount of preventable harm, ranging back to the early 80s and 90s, both in inpatient and outpatient, acute and chronic. And the data suggests that perhaps as much as 5 to 10% of patient encounters have an element of preventable harm, both morbidity and mortality. And despite a huge focus on these issues since the Institute of Medicine report about 12 to 14 years ago, we still struggle to have large improvements that are sustainable across the system. What's become abundantly clear in these events is what tends to fail is the clinical microsystem, that is the system that takes care of the patient, the physicians, the nurses, the social workers, the pharmacists, the management. And so when you look at these issues across the system, you realize that the opportunities around communication, coordination, and focusing on the needs and the journey of the patient continues to loom large. That is to say, we continue to measure this at the point of harm and not necessarily focusing on metrics that follow and track the journey of the patient from their home into the hospital and back from the hospital back to home. As Julie noted, this issue is not unique to the U.S. It's across the Western world at least, and certainly in some other developing countries that have studied this. And the adverse events or death are perhaps as much as 7%, as well as 20 to 30% of preventable harm, depending on the acuity and the severity of the underlying patient conditions. What you can also see is that when you compare healthcare systems across countries around the world, this lovely study from Health Affairs called Mirror, Mirror on the Wall compares the U.S. healthcare system to the other 10 lead Western democracies, and in it you can see that across a variety of metrics that the Institute of Medicine highlighted, that would be quality and access, efficiency, equity, lives centeredness, and cost, the U.S. does not fare as well as it should, and it's the single most expensive system. And again, this highlights this question of value. Are we getting value for the amount of resources that are being spent? And the value, first and foremost, is defined from the view of the patient, from the view of the providers, and then from the view of the system. What's also very clear from this table is that this focus on patient-centered care is something that we could do much better. That is to say, how do we align our measurement tools? How do we align our oversight so that it's constantly and relentlessly focusing on the needs and values of the patient and their families with them? If you had to summarize some of these challenges, again, which have become apparent both in quantitative and qualitative studies, in descriptive stories as well as randomized controlled trials, there's a lack of coordination or fragmentation of service. Patients want more. They want to see what the care is about. They want to better be part and co-producers of this care. The lack of active follow-up means that patients get readmitted more often. There's not enough continuity between the hospital and the community. Large variation in outcomes, as much as 5 to 6-fold, which is well demonstrated in the Dartmouth Atlas. It's demonstrated in other places. That is to say, your zip code and your geography will dictate the quality of your care, and obviously that is not consistent with the overall goal of providing high-quality care for patients. Not enough transparency in what the outcomes mean. And finally, and perhaps as it relates particularly to learners, a growing sense of unhappy workforce, of burnt-out physicians and nurses, of high turnover of providers, which is adding both to the cost as well as to the fragmentation of care and the inability to sustain the joy and passion that these providers bring to their work every day. In the slide in front of you, we tried to highlight when one compares the risks of healthcare to other high reliability or ultra-safe industries, working from the left, so this would be bungee jumping and mountain climbing, which are well known to be very risky, lots of harm, lots of near misses. Then as you move more towards the right, the chemical industry, aviation industry, and the nuclear power industry. Another way of looking at this slide is 6 sigma. On the right is 6 to 7 sigma. On the left is 1 to 2 sigma. And you can see the healthcare straddles between 2 to 3 sigma. As an anesthesiologist, we've pushed the boundaries and we've made healthcare so much safer. But despite that, moving from a 3 sigma to a 5 sigma, still in high-risk patient care, ASA 3s, for example, sick patients, the data suggests that we're still harming about 1 in 100 patients. So again, lots of opportunities in which the system does not necessarily deliver at the highest opportunity and still creates preventable harm, both as you track it on cost, as we discussed earlier, as well as when you track it on the number of lives lost or the number of encounters in which a fatality occurs. And as you can see here, we're way beneath other industries, both as it relates to overall harm and as it relates to process improvement. Finally, I wanted to highlight Jim Reason's seminal model from 1997, which you're all familiar with, this Swiss cheese model, and to highlight several issues about this model. Number one, that providers, nurses, and physicians, and pharmacists, and social workers are all constrained or enabled by factors at management and the macro system. So the insurance companies, the regulators, the management create the conditions for nurses and physicians to deliver optimal care. The providers perhaps make the mistakes, but the enabling factors, if it's the number of nurses per patient, the number of resource equipments per unit, or the number of overall time to focus and reflect on the care, all these play into a model that creates the conditions for adverse care. In all the cases in this book, in all 24 of them, you'll see that we've analyzed these cases using this lens, or lenses, I should say, in which the organizational, the technical, the cultural, the oversight, the overall employment model, all these things play into and create the conditions for either optimal care or suboptimal care in which harm is caused and directly attributed to these triggering factors, which again can be organizational, they can be cultural, they can be financial, they can be technical, but perhaps above all is the feeling of psychological safety when the providers feel safe to speak up when there's a problem, when they're able to voice their concerns, and when they feel that their voices are listened to as it relates to identifying opportunities for improvement and as far as translating these improvements into optimal patient care. I'd like to hand this over now to Helen to tell us about Lewis's story. Helen?
Thank you, Paul. Well, I will get right into the story. This is my son, Lewis. You see on screen, he died of medical error nearly 14 years ago. Nearly 15 years ago, actually. So I want to take you back in time to 2000, when I was a mother of 2 children in Columbia, South Carolina. Lewis was my eldest child. He was a star student, an athlete, a musician. He was a child who walked off with all of the middle school honors that most of us forget about as life goes on, but they still loom very large for us. And this is why. Lewis had a condition called pectus excavatum, which is a sort of indentation of the chest wall caused by the breastbone not growing straight. It's primarily a cosmetic condition for most people, as it was for Lewis. And we had never really thought about doing anything about it until we saw an article in our local paper. It was talking about a safe, new, minimally invasive procedure to correct pectifects or bottom. The article talked about a quick recovery and excellent results. And we called our pediatrician. One thing led to another. And in November of 2000, day after Halloween, we took our son Lewis to the hospital to have his pectus defect repaired. It's hard to compress the story of what happened in the hospital into just a few minutes. So if you want the full story, I do suggest that you read the book chapter. But briefly, after surgery, Lewis was prescribed a full adult course of the painkiller Toradol, in spite of the fact that he wasn't producing urine. And as many of you know, Toradol, ketorolac, is an injectable NSAID painkiller that's widely used in hospitals, but it has a number of restrictions on its use because of the many adverse events that can be associated with it. And these include kidney failure, bleeding, and ulcers that can perforate without warning. And this last is what happened to Lewis. So this is how it happened. 3 days after surgery, about half an hour after a Toradol injection, Lewis was suddenly overwhelmed by excruciating pain in the area of his stomach, pain that was described as a 5 out of 5 on the pediatric pain scale. It was different from anything he had experienced before. But nurses quickly came to the conclusion that this was an ileus, constipation, due to the other narcotics that he was taking. So over the next 30 hours, that assessment stuck like a burr and transformed into the official diagnosis as Lewis's symptoms grew progressively more dire. So his abdomen became distended. He got paler and paler. He had huge circles under his eyes. He had a constant cold sweat. And his vital signs became more and more erratic. And finally, when they came to take his blood pressure the next morning, he had none. It was the weekend. He hadn't seen an attending physician for over 2 days in spite of my repeated request. But on the morning that he died, nurses and residents spent over 2 hours scouring the hospital for a blood pressure cuff that would detect his undetectable blood pressure. But even then, they didn't really appreciate the severity of his condition. They were astonished when he went into cardiac arrest and died. An autopsy the next morning revealed a giant duodenal ulcer of a type that's usually associated with NSAID overdose, and nearly 3 liters of blood and gastric secretions, about 3/4 of his blood, in his abdominal cavity. This is this process map is an illustration in the book, and it highlights the major events in Lewis's hospital stay. It's something that people often find helpful in understanding what happened and in trying to teach with the case. I just wanted to show you that. I know you can't read it on screen here, but it is helpful about answering questions about what happened to Lewis. And I'm not going to go into what happened after our son's death, but I will say that the main focus of our lives since then has been in trying to bring improvement to the system that caused his death. And to me, that's one of the big lessons of this book that it can hold for healthcare providers. It's sometimes easy to forget when you're seeing only snippets of people's lives that to families these are earth-shattering, life-changing events that echo down through the generations. Most of the stories in our book, including Lewis's, have an afterstory of the family's attempt to bring about learning and improvement in the name of their family member. People are incredibly generous and forgiving, and that's not always easy to know when you're on the other side of the event. But people know that mistakes can happen, even mistakes with devastating consequences. And what they want is for the enormity of the event to be recognized and the life of their loved one to be respected by the learning that can come from it. And that is really what lies behind this book. I think the lessons for patients and families are often pretty similar. There are a lot of similarities to these stories. When you look at them as closely as we have, the similarities really jump out at you. There are a lot of technical similarities, things like weakened care, failure to rescue, sepsis, certain medications. And there's a list of advice that you see all the time for patients, things that people should do. Do your homework, keep a list of your medications, know who your providers are. And those are all important. But I think that the fundamental problem for patients is that they can't do this without your help. Patients need an invitation. For patients, the term patient engagement is really a misnomer. Patients are usually engaged in their health care, but they often meet a brick wall when they try to exercise that engagement. So what we need, and what I think we all want, is the co-production of care, health care that's worked out together using the expertise of both patient and provider. And this is something that we all need to do, with patients learning how to step up to the plate and providers becoming more sensitive to the needs and preferences of their individual patients. And with that, I'm going to pass it over to Julie to talk about how we can use the book in teaching.
Thank you, Helen. As always, you know, you tell the story in such a compelling way, and I'm sure everyone on the line today, you know, feels that as well. I first met Helen, I think it was probably 2004, maybe 2005, and I was just overwhelmed by her story about Lewis. And, you know, as a younger faculty person, I was wondering about how I could use stories to teach. And so I asked Helen if it would be okay with her if I'd be able to use Lewis's story and develop a case. And we actually started with that process map that Helen showed you a few minutes ago. We started with that as our basis for teaching. And what we found was that we had created a very powerful tool for teaching about an adverse event and really kind of bridging that gap between the patient story and what we needed to learn as healthcare professionals. So, you know, from there, we developed a full case around Lewis's story, and then I had some people ask me for other cases, similar cases that they could use for in-service trainings. So what we did then was we developed, you know, the book that you have in front of you now, because what we really wanted to do was get from that point about these, you know, sometimes horrific stories that are very compelling about the state of safety in our healthcare system, but how do you move from those stories to actually teaching with them, learning about them, translating them into core competencies for healthcare providers. So that's what we tried to do with this book. And, you know, just, you know, as I was thinking about this, you know, in 2004 about how to use patient stories, I'm just curious, and we're going to try to do a little poll here about how many of you on the line have used patient stories as part of your teaching. So if you're able just to check on the box there in your control panel where you can say a yes or a no, and we'll kind of get a sense of how many people have been able to use stories. I see a few people clicking on. So I'm seeing more and more check marks coming through and some hands raised. So I think I'm getting the sense that several of you have tried this, and that's great. And I'm really excited to hear that you've tried to integrate patient stories into your teaching. And maybe in a few minutes we'll get a sense of what some of the things that you've done as we tell you about how we've tried to use them. So as we were developing this book, you know, we knew we had to create a framework for learning about the stories, and it seemed to us that an obvious link would be around the core competencies in healthcare. And as we're working on this book, and it took us probably about 4 years to come from the conception, from the idea we wanted to create the book until it was actually published, there was this article that was published by Bob Englander and his colleagues that reviewed 153 health professions competency lists. So we organized our book around those core competencies, and it's a framework of competencies that's for healthcare professionals of all types, so not just physicians, not just nurses, but ones that are robust enough to cut across multiple different health professions. There are 8 competency domains, and I'll pull those up for you, around patient care, knowledge for practice, practice-based learning improvement, interpersonal and communication skills, professionalism, systems-based practice, interprofessional collaboration, and personal and professional development. Now, some of these are, more traditionally taught in healthcare programs. Patient care, for example, is one that we've done a pretty good job at. Some of them are more challenging. Some of those around the interpersonal and communication skills, professionalism sometimes is more challenging. Systems-based practice is particularly challenging. And what we found were these stories are really excellent ways to teach those core competencies. So each of the cases that we've organized in those, each case fits into this framework, and we've put 3 or 4 cases within each section, which is organized around a core competency. So I also want to kind of move from thinking about how we use stories in our classroom setting, but how many of you have actually used patient stories for teaching the interprofessional competencies, so the core competencies around care? Can I see another show of hands? That's great. I'm seeing more people start to jump in that you've also been thinking about doing this. So what I hope that we'll find is that I want to hear a little bit from you about some of the things that you have done as we start to talk about how we've used the stories. But then I hope that you'll find that this will be another good resource for you to use in the classroom. So what we've thought about is we've had a lot of experience, Paul and Helen and I, in using these cases as well as other stories in the classroom. So we came up with some ideas about how we would use this and how we have been using it. For those of you who are teaching a semester-long course, or something around a 12-week course, you could actually structure your course around those 8 core competencies, and then you could use the cases as you work your way through the competencies. We also think that these case studies work really well in a flipped classroom where you assign the students to read the case prior to coming to class. They come prepared. They've read in advance. I know sometimes that's always a challenge, but then you have that time during the classroom that you actually dig into the questions. You have small group discussions around that. Also, we've been successful in using these stories in some role play scenarios where students come and they take on different parts, and they are able to have some of the difficult conversations around adverse events and understand from the patient perspective of what it's actually, some of the experiences that they might be going through. And then also it can be used to develop simulation and standardized patient encounters, the OSCEs. And and whether you are creating a standalone course that uses the book as the textbook, I think you can also use cases individually to supplement existing courses on quality and safety. And that's really how I started with these cases, is that I would bring them in, and essentially I was testing them as we were developing the book. I was testing the cases in the classroom setting based on whatever courses I happened to be teaching. That I'd bring them in and I would use them in the course and see how students reacted to them, see what other types of questions they would come up with. So I think they can be very powerful to be used in the class assignments. And then I think you can also integrate some of the quality and safety tools, for example, a root cause analysis or a failure modes effect analysis. You can actually apply some of those tools to the cases so students can kind of jump in and start practicing using some of those tools and see what they can come up with. And you see a little bit of that with the process mapping that we did around Lewis's case. Some of the other cases don't have process maps, but you could create one as a classroom assignment, and that's another way to enhance the student skills around some of those quality improvement and patient safety skills. So I would love to hear from some of you about how you've started thinking about using cases in your classroom setting, how you use patient stories. If you have any experience with that, I would love to hear from some of you who are on the line.
Great, thank you, Julie. And I will also just remind people, if you want to ask a question, you can do that in the chat box on the right-hand side of your screen, or you can also press *1 on your telephone keypad. April, do I have that correct, the instructions for asking a question?
Yes, ma'am.
And I do have some questions coming through on the chat box right now. Let's see, first question. These stories are very powerful. How would you recommend introducing them into the classroom given their ability to trigger deep emotional responses? What has been your experience with debriefing healthcare providers?
Well, that's a fantastic question, Sophie, and it's a difficult one. I mean, you're right. These stories are very compelling. They're difficult to read. They're difficult to experience. They trigger strong emotions in the students. Sometimes they trigger strong emotions from people who might have an experience as a patient or as a family member. They also trigger strong emotions from healthcare professionals who may have been involved in an adverse event. And you have to think about that when you enter into this world in the classroom. So you have to be prepared. And I think one way to do that is that you have to make sure that you set aside enough time to be able to pre-brief, to talk about, okay, we're going to be dealing with some difficult patient safety events, but we need to do this in the classroom. It's a safe setting for having these conversations. But then you also have to have time for the debriefing afterwards. And that was a mistake that I made early on as a faculty member, is thinking that once I did the exercise, I was done, not understanding that the debriefing is as important as the actual exercise, to have that chance to talk about the experience. And Paul, maybe you have something to add to your use of the cases as well.
Yeah, one of the most powerful things from teaching healthcare providers for the last decade using these case studies has been, once they hear a story like this, they feel very compelled to share their own stories. And I think, again, going back to the need to allow quite a bit of time to allow providers to acknowledge their own journey and stories, and the catharsis that comes from talking about these cases. Many of them, they'll say they've never shared it with anybody before. And so the power of these stories to evoke repressed memories where they weren't allowed to speak up about it, or they didn't know how to analyze it, or perhaps more difficultly, they felt guilty because the system set them up for a painful event in which harm happened because the system was not designed for safe outcomes. They were the ones that chose the wrong dose, or gave the wrong procedure, or chose the wrong thing, when in fact, when one digs in deeply, it was a systems problem that allowed it to happen. And so how do we help them think through this as a way of learning and action, and as a way of realizing that although they were responsible for the actual final step that led to the patient harm, in fact, it was part of a systems failure that enabled this process to happen, and how to best deal with that, what Al Wu talks about, the second victim, in which they feel so responsible that many of them have either left medicine or limited their care because of their sense of responsibility for being part of this process. So, huge question, very, very difficult.
Great, thank you, Paul. We've actually got quite a few questions coming through on the chat box as well as in the Q&A. What is the advantage of trying to measure beyond Six Sigma?
I think it's a great question. You know, process improvement, of course, is not something that one solves, but one designs a value stream that continues to shed light on the process, focusing on the shop floor, on the providers. And so by continuously focusing on systems that can do better and better in reducing process failures, one constantly gets insights into how to improve everyday practice. And the nature of complex socio-technical systems is that some parts of it will be highly refined and some will be not so refined. And so focusing on higher reliability and ultra-safe tends to drag the entire system towards a better understanding using a language, using a mental model and frames that allow people to realize that, in fact, they could refine the process more and more around that axis of better care, more timely care, more respect for the patient, uniquely designed around what the patient wants and expects from their interaction. And so the focus on higher levels of reliability, we've learned, drags the entire system to the right in that graphic. That is to say, when you focus on high reliability, the entire curve shifts to the right, so that even areas of the organization or of the service line, if they're not as reliable, they tend to feel more pressure and more focus on becoming more reliable. And so it becomes a way to push and encourage the entire system to become more effective in delivering better process and outcomes of care.
Great, thank you. We do have a few more questions on the chat box and the Q&A, but I just want to pause for a moment to ask April if we've got anyone on the line who would like to ask a question.
Your first question comes from the line of Melissa Bruton with Wharton County Junior College.
Hi, I'm sorry. My question is more of a comment on thank you, Helen, for sharing. I went to a conference and we heard about a person who lost her mother in a fire, and it really does make a difference to bring real patient scenarios to the student to help them with their studies and to make it more personal to them.
Thank you for that comment. I appreciate hearing that, and I think it's really important, because one of the things that I often see is that students are really unaware of the risks that are part of what they are going to be doing every day, and they need to learn about that. And I don't need to know that it necessarily has to be shock therapy, but I think it's very important that they understand that these are, that everything in medicine, all benefit is accompanied by harm, and that there is a ratio to be achieved. So thank you for that comment.
Thank you.
Great. Thank you. A couple more questions on the Q&A. Do you ever bring in patients and families into the classroom to share stories directly?
Well, I'll start with that. Yes, absolutely, and we do at times, and also now I'm starting to do that even more now that I have this book in hand as a way to, it's another way to bring the story to the student. So we have the case study, we have the some of the tools that are in the case studies. We have the classroom discussion. We can also bring the patient or the family member in as well. I think that's more challenging. You have to work very carefully with people to do that. But there are people who want to tell their story and who need that opportunity or are looking for opportunities to do that. So I have been able to do that. I mean, Helen, what is your perspective of that about finding people to bring in to tell their story, or how do you start to work with some of the people who want to share their stories?
There are a lot of people around, and there may be people in your own hospital that you find out about. There are probably people in your local paper who are in the phone book if you really, we're seeking people out. I think, in general, that there are a lot of different, people vary a lot. People will have a lot of different attitudes, but I think it's sort of educational. I have had people say, well, what if they're angry? And others say, well, people need to see that. Healthcare providers and future healthcare providers need to see that. I know that's a minority point of view, but I think it is helpful in that it tells people, really how important these things are, that one needs to respect the tools of medicine.
I think Paul has a comment about that as well.
Yeah, I think it's hugely powerful to bring in patients and family members. I think what's very important, of course, is to have a structure for that interaction. And one of the, I think, valuable lessons of these tools in the book is offering a structured way, a structured analysis of how to invite the storyteller into the process and then to facilitate that interaction between the storyteller, the story, and the listeners. And that, I think, is can be tricky at times, but I think perhaps by meeting with the patient and family beforehand and talking about some of the dynamics and what might be potential challenges, perhaps emotionally or interactively during the session, my experience has been uniquely positive around bringing in patients and families. Again, you need more time because of the nature. It's hard to script it. And so I think it's incredibly valuable, and the students will not forget it. And hearing that first voice story or from the patient or from their family becomes a wonderful reference point for further interactions with the students. And I think invites them to realize that these aren't just numbers when we're talking about improvement. These aren't widgets. These are real people and real family members, and the suffering, not just the harm, but the pain and suffering that the patient and their family undergo is something that must be brought into the classroom as a way to both engage the learners and to imprint the lessons of quality improvement and safety into them as they progress in their journey as future and current healthcare providers.
Thank you, Paul. Another question coming through in the chat box. Do the cases reflect the various transitions of care?
Well, our cases range, lots of different cases. So I think by the transitions of care, I'm imagining that you're thinking the transitions from one care setting to another care setting within the hospital, and also from the hospital back into a home environment or another type of care setting. So that's what how I'm interpreting the question. And so the answer is yes, they do, because there are a range of different types of transitions, a range of different types of cases that are presented.
And I'll jump in here as well. As you all know, one of the key emerging themes around quality of care is the vulnerability of patients at points of transition, either between shifts or between departments or between jurisdictions. And more we're discovering that many patients fall in those holes between the elements of the healthcare system because of the lack of seamlessness. And so what emerges in many of the stories are how the problems, the underlying issues of the patient are magnified because of poor coordination between one level to the next level of care. It could be between the community and the hospital, or the hospital and a nursing care facility, or between wards within the hospital. And so the focus that we've done around readmission prevention and handovers and handoffs of care comes out throughout the chapters as a unique opportunity to better understand where are the most opportunities for process failure happening, and how do we better understand how to bridge these different jurisdictions so that transitions between units of service, either in the hospital or between the hospital and the community, or between clinical elements in the community, how can they better be highlighted and reinforced as a way to prevent future harm?
And, you know, one thing I would add is that all of these stories go from the beginning to the end. That is, they go from before the healthcare encounter, giving a little background, to the results of it, really leading, we lead most of these people off, at the time that their chapters were written. So you do have the full scope of these patients' experience, and I think that's one of the really valuable things that is missing in most case studies. So it's all the transitions that they have had, not only between providers, but to home and afterward.
That's a great point, Helen. It's not just the transitions, the healthcare transitions, as I was interpreting it, but it's the transitions to what happens after the story that you were highlighting when you were talking about Lewis's case.
Great, thank you. We do have more questions on the chat box. April, do we have any other questions on the line?
There are no questions at this time.
Okay. So the next question is, are the cases, or any of the cases in branching case format? In other words, the case is given, step 1 decision takes place, then step 2, but it branches depending upon the answer given by the students in step 1.
No, that's not the way that we structured the cases. We structured the case with hearing the story from the patient perspective as the patient or family member experienced the story. So sometimes, you read the case and you'll be like, well, I can't imagine that would really happen, or that can't possibly be true. And Paul and Helen and I had a lot of conversation about that because some of the clinical findings we weren't really sure about. But we came to this conclusion that we had to tell the story as it was experienced by the patient, and that's how we reflected it. So their whole story is there, and then we try to highlight some of the points that we think are important teaching points in the case discussion, and then following up with the questions.
Great, thanks, Julie. One other question coming through, with the development of decision support systems, CDS, DCS. Sometimes the DCS comes with the EHR system. What do you think? How can this DCS be used to support patient safety? I think I've read that question correctly.
So perhaps I'll take a crack at that. So I guess, how can patient stories be used in a system where there's decision support systems? Ultimately, decision support systems are based on optimal frameworks and architecture of data. The stories ultimately are the glue that really holds it all together. And so, I think one can use the decision support tools as a way to support the stories and to bring out what was the diagnostic information available, what was done to the patient, and to use that as a way to dig in deeper into the system. I think ultimately healthcare providers are storytellers, and stories is how we convey our values and our culture. And these stories are about how these providers form, and in that formation, how can the information systems, in this case, EMR, EHR, or CDS, can be used for that. So I think that might be a way to think about that type of use of tools to support those information systems, not as sole systems, but in conjunction with the story of the patient, supported by the information systems.
Great, thanks, Paul. Let's see, one more question. How do you assess students when using the book in the course? Written case studies or discussion?
Could you repeat that question? I didn't understand what
it might be a little bit unclear. How do you assess students when using this book in the course? What sort of assessments do you use?
Well, I mean, that's an interesting question. As part of a larger course, so I wouldn't have, my courses are based, do you show up and participate, and then, type around some written assignments more so than assessing them on completing the questions that are at the end of the case study. So my assessment is a larger issue around the entire course. What I would think about doing, though, and what I will think about doing, is actually designing some of the written assessments based on those questions, so they can prepare an essay or work in a team to create answers to those questions around a particular case. I would also give flexibility around which case they want to choose to create a written response to, so they can choose one that they feel is more compelling to them from whatever their perspective is, and then let them create a written response to that.
And I'll just enhance that point and say that we look at education more as professional formation. And I'll call your attention to the wonderful final essay in the book by David Leach, who used to run the ACGME, and that the journey of these students is the formation of their character as well as their professional competencies. And so if we frame the question as that, how do we measure their formation? So what are the formative and summative tools to better understand how they've learned, and how do we use these stories as a way to evoke the types of lessons that they need to learn? And so based on that type of framework, using a traditional knowledge, skills, and attitudes competency assessment, we want to understand if they understand the knowledge needed to deliver the care in case, the skills required to communicate authentically and honestly with the patient and their family, the ability to reflect about when things go wrong and how to analyze that, and then the attitudes that go along with these types of events, understanding the event, telling truthfully to the patient, dealing with the emotional anger, all these things we've used either written assessments or in simulations or using standardized patients such as OSCEs, all these tools. We have some structured tools that we can share offline, but all of them are ways to use them as they relate to real patient stories and a way to assess the knowledge, skills, and attitudes of the learner based on their level, either undergraduate, graduate, or postgraduate, as a way to give the teacher the ability to understand more fully, has the learner achieve these milestones as it relates to either care provision or care oversight, or ultimately around delivering and understanding how to design a better, reliable healthcare service.
Great, thank you, Paul. Looks like we have one more question coming through on the Q&A. April, are there any questions coming through on the line?
There are no questions at this time.
Okay.
Sophie, I wanted to bring up one of these questions that it was on the Q&A earlier, and Billy Sharon said that it becomes extremely difficult in clinical settings when the staff in the clinical area do not understand system process improvements and continue to cover up near misses for fear of retribution or punishment, since the C-suite doesn't create a safe culture. And I realize that's not really a question, it's a comment, and it's a very valid statement. But I think that these cases, from what I've experienced, they give people a way to bring in a story that is relevant but not so pointed that this story happened here and we need to talk about it right now. So I think it's a nice way to get into this topic of how do you create a culture of safety when you can bring in a case from somewhere else. And I've had people tell me this, that this is the way that they've used them, where they bring in some of these cases into the boardroom, for example, to talk about, or to different in-service trainings, and they can talk about, say, well, here's a story. Do you think something like this could happen here in our hospital? And that is an opportunity for people to start to talk about these very difficult issues and in starting to create a safe culture. So that's just one thing that I wanted to bring up from my own experience. And Paul, maybe you have something to add to that.
Yeah, it's a huge and important question when there is a disconnect between management and the staff as it relates to the importance of inviting staff to speak up and to be authentic in their interactions. We know very clearly that toxic cultures, as Ron Westrom and Carl Weick and others speak about, toxic cultures in which providers want to speak up but are thwarted by either direct or indirect punitive measures, ultimately undermine the reliability of the system. And so speaking directly about the culture, that is to say, do people feel comfortable speaking up? Can they do it safely? Are near misses seen as valuable opportunities for improvement, or are they seen as opportunities to isolate, ridicule, and embarrass providers? And that perhaps is at the crux of delivering higher reliable care, and emerges very clearly throughout this storybook, in which some providers knew the answers to some of the issues, but either were not comfortable speaking up or were not encouraged to speak up. And ultimately, when events happen, it became apparent that those nascent factors, if they would have been addressed, might have prevented the ultimate escalation to patient harm. But because the culture doesn't encourage that, it becomes very difficult to prevent these events from beginning. So I think that really is at the heart of what this book is about, which is focusing on how do we enable that culture of being more honest and authentic, and inviting providers at the sharp end to speak up honestly. They find their joy there, that reinforces their loyalty and commitment, and ultimately we know that's a clear driver, as Amy Edmondson says, a clear marker for organizational reliability is when staff can speak up and feel the psychological safety, the comfort level to safely speak up and not be punitively behaved against them or harmed later on.
Thank you, Paul. We actually do have one more question coming through on the chat box. Do these cases explore alternative care sites such as rehab, outpatient, or long-term care settings?
We don't really have any long-term care settings. I'm just thinking, I'm running through the list of cases in my head now. There aren't any, so they're hospital-based, primary care-based care settings. And so that's, I guess that will have to be our next book. So I think, stay tuned for the next set of stories. And it's not that those stories don't exist, because they do. And Helen will confirm that she has stories, that we could do. And in fact, someone told me, asked me if we do one that just focused on long-term care settings because of the adverse events there. So, I think there are more opportunities to write more stories.
Great. Thank you. There is actually one more question. Is there an audio that goes with this book where the students can hear the stories being told? And no, there's not currently any audio that goes with the book, but that's a great idea and certainly something that we can look into.
Well, let me add to that, Sophie, that actually the way that we wrote these cases is that we started by interviewing the patients or the family members. So we have audio and video. We actually videotaped many of them. Some of them are just audio, some of them are audio and video, and so we do have that resource. It just hasn't been developed. That's in our vault at the moment. So if there's a way for us to produce that, we're happy to make it available. It would have to be a partnership with Jones and Bartlett to do it, though.
Well, that's certainly something we can explore. Thank you. If there are no further questions, I will take us to the next slide. And I just want to thank Julie Johnson, Helen Haskell, and Paul Barach for providing their email addresses to, if you have any further questions after the webinar, you can certainly reach out directly to all three of them. Julie can be reached at Julie K. Johnson at northwestern.edu, Helen at Haskell.helen@gmail, and Paul at pbarach@gmail.com. And then finally, I wanted to point out that we are pleased to offer complimentary desk copies to qualified instructors. You can fill out a request form by going to go.jvlearning.com/patient-voices, or you can simply reach out directly to your account specialist, and I've listed out everyone's names and contact information here. And as I mentioned at the start of the session, I will be following up via email with a link to the recorded session as soon as that's available. I'll also include a copy of the slide deck, as well as all the contact information that I have for you here. I'll send all of that around in an email. So a very special thank you to Julie Johnson, Paul Barach, and Helen Haskell, and thank you to everyone for joining us today. And with that, I'd like to ask our operator to go ahead and end